Hi everyone, this is an overview for the continuous infusion of fractionated heparin protocol. You will see once you get to API and work in the hospital, most hospital that you're going to be working at is going to have heparin infusion protocol. And just take note that this is not the heparin sub-Q, dosing that you use for prophylaxis, but this is an heparin infusions where you use it for more like a big indication like ACS or active clotting like VTE or AFib. And the reason why most hospitals have heparin protocol because heparin is considered as high risk medication. The adverse events, if we don't appropriately put them on the right dosing of heparin, and if we don't monitor it, they can bleed, right? And it can be very fatal if we are not careful with this medication. And another thing is that because of its high risk, we have to monitor the patients very frequently, and it takes a lot of process and system algorithm to make sure there's no how what to do to monitor the patients, to make sure physician knows how to order it, to make sure pharmacists have a set process to follow and step by step process to follow so they don't make any mistakes or error while verifying the order. So most of the heparin protocol will sort of line out how physicians should order the heparin protocol in this, as protocol initiation. And then they will have multiple indications to choose from. Sometimes they will have order set specific for indication, or it can be just general heparin order set where they can choose what kind of things to monitor, what doses to order, what goals of levels to expect. So those are kind of like the ordering part for the physicians. For our part as a pharmacist, you'll get the order from the physicians and you will have to assess the order. You have to review based on the patient factors to see if it's appropriate to start the heparin, and then you have to review in terms of the dose, if it's ordered correctly. And then you have to review in terms of labs, other parameters to see, for example, are they bleeding currently? Are the hemoglobin platelet are okay? What about the PT-INR? All those coagulopathy lab that we need to take a look at baseline before we can start the heparin. So those are some of the big roles for the pharmacist. And then once they kind of go over how to order and then how to verify it, they will go through the dosing and monitoring in terms of how the process are, what's the step-by-step process. Initial dosing typically will depend on the indications of why the heparin is being started, and those are ordered by the physician or diagnosed by the physicians. And all the dosings are going to be weight-based dosing, both the bolus and the continuous infusions, as you can see in here. The continuous infusion will have a time aspect to it because it's an infusion, right? So you dose it as a rate unit. So there's always like per hour or per minute. A lot of the hospitals or a lot of the EHR will use per hour for the heparin infusion. And because it is weight-based dosing, heparin wise, you'll have a cap in terms of how much max you can dose the patients. A lot of times we'll see very heavy patients, and when we calculate the weight-based dosing, it will be like super, super high, like in the 10,000s or something like that. So, and that can increase the risk for bleeding, right? And so a lot of times we cap those high-risk medications to a certain amount, max as an initial dosing, and we can monitor the patients carefully, regularly, and adjust as needed if they are subtherapeutic, for example. And there is always sometimes there will be different goals for the levels that we'll be getting based on the indications. And the levels that we'll be getting can be different from hospital to hospital. Most of the hospitals I see use anti-10A, but there are some other hospitals that we use APTT. So those are just some things to take a note when you start in the new hospital. Monitoring wise, typically it will fall under the nursing staff responsibilities, just because it requires a lot of contact, to get the blood, and then they will be the one who adjusts the rate as well if it's under protocol. So a lot of times it goes under nursing, but it is very important to know on how the monitoring process is done and how the dose are adjusted by the nurse, so that we as a pharmacist, when we saw the order being increased or anything like that, we know what's going on and how to proceed with that order. So the nursing, like I mentioned, like they will be the one who monitor. In the beginning, it's going to be like multiple times per day that they will monitor until the levels become therapeutic and they can go less frequently. And like when they monitor and follow the levels, there will always be the next step in terms of like, what if the dose needs adjustment, right? What if it's subtherapeutic or supratherapeutic? What do we do? So all the protocols or like the order set will have those direction in terms for the nurses, so they can follow in terms of what to do. When it's subtherapeutic, usually will increase the rate, or if supratherapeutic, that obviously will decrease the rate. And there's also, if it's therapeutic, then you can obviously continue the rate at that time. If it's like super, super high, the levels, typically like there is some protocols where they would ask the nurse to hold the infusion for a certain period of time, and then they can resume it at a decreased rate. So those are how the heparin protocol usually go. So just be careful, or kind of read through carefully specific protocols. You can use this protocol for case-based courses, but once you get to API or once you practice as a pharmacist, different hospital might have different protocols, and there might be like differences in the details that I was mentioning earlier. So just kind of pay attention to those details.